So hello, everyone. Warm welcome to you. And it's always a pleasure to receive you for the IA2030 Impact Accelerator. And this is the third hackathon that we are holding. We are actually in week 3 of the IA2030 Impact Accelerator. And as always, I am here with Jenny Sequeira. Hi, Jenny.
Hi, Charlotte. Hi, everyone. A warm welcome to you.
Yeah, and today it is not an ordinary hackathon like the others. It's a special hackathon because we have some special guests with us. That is the members of the Immunization Agenda 2030 Working Group 1 that is focusing on primary healthcare and universal health coverage. They're here not to speak to you, but just to listen mostly. But I can see the chair of the IA2030 Working Group 1 that's already with us, Folake Olayinka. Welcome to you, Folake.
Thank you so much, Charlotte. It is exciting to join you today and to listen and learn from your experience and really looking at how we can, even right now during COVID-19 vaccines, roll out, safeguard, and also strengthen routine and essential immunization. We know that this is really critical because the protection of children against vaccine preventable diseases is extremely important and cannot take a backseat at this time. Otherwise, we'll be facing other disease outbreaks. So really here on behalf of the working group to listen and learn from your experience today. Thank you for having me. And warm greetings to everyone. I see many names, people that I know. Thank you all.
Thank you so much, Folake. And I just want to recognize also the other members of the working group that are here, Thomas O'Connell, and also other partners that we work with IA2030, that's from Bridges to Development, Alan Brooks, Eda Magnus. We have Ian Jones, that's also with us. So warm welcome to you. Now, if you have not yet shared your challenge with us, earlier on, Emmanuel Musa was talking about a success story. Share them with us. I'm just putting the link once again in the chat so that you can receive help from peers on how to address these challenges. That's the reason why we are here. And why do we organize these hackathons, these short sessions for experience sharing? It is because during the application process for the IA2030 Impact Accelerator, we ask you, do you wish to meet your peers for shared sessions to share experience? And over 90% of you responded yes. In fact, over 60% said you will make it a priority. That is why we thought it wise to have these sessions during which you will get to share your experiences to help peers overcome their immunization challenges as well as learn from them. So what is a hackathon? That is each hackathon is immunization training a challenge. It's short 30-minute session for peers to problem solve the challenge that are facing as far as immunization is concerned. So during this session, we identify a challenge. If the challenge owner is there, we may turn to them to fill in some gaps or maybe or complete some information about their challenge. But the focus will really be on you who are here in the room with us to share your experience, about that challenge. You are not going to prescribe to the challenge owner what they need to do, but you will be sharing your experience to say, you were faced with this challenge, this is what you did, and this is how it turned out. So I'll really be turning to you all in a short while to invite you to raise your hand and to share your challenges. So the challenge owners get to consider a number of questions while they are sharing their challenge. So today we are going to be looking at the first challenge we are looking at. Let me just see if the challenge owner is with us. I see, okay, Buma Otobo is in the room with us. And what is her challenge about? So Buma's challenge, she says the healthcare workers are also engaged in ongoing mass COVID-19 vaccination campaign. So their attention is definitely divided by having many activities at the same time. So I would like to turn towards Buma, if you can just explain a little bit more your challenge, and while she's doing so, please get ready to share your experience around this and to help her to overcome this challenge. Over to you, Buma, and please do start by introducing yourself.
Okay, so hello everyone, and thanks for having me. I think I should apologize for a noisy background, so to say, just rushing in from the field and just decided to tune in right away. And hi to you, Olayinka, I see you, and good to see you here today again. So hello everyone, like I did say, my challenge, you can see, has to do with the healthcare workers who are busy, especially at this time of the year. We have the ongoing COVID-19 vaccination, and we have other activities. Emmanuel Musa, thank you so much for sharing. You can see he also talked about measles campaign just concluded. NIPDs are coming on. So the issue really is that we still have the same healthcare workers who are the ones going to carry out practically all the activities that have been lined out. And that wouldn't have been a problem if we had adequate number of healthcare workers manning our facilities. But the issue is there are gaps. A lot of gaps exist. And so we do have these problems over and over again. And so the next question will be, why does this matter? Yes, from my goal, which I shared some 2 weeks back, the goal basically was to reduce the number of high unimmunized and zero-dose children by engaging the healthcare workers, the LGAs, and as well as the healthcare workers themselves. So from that goal, you can see that we really have a lot of children that are still being missed during outreaches and also perhaps during fixed sessions. So of course, when you have children missed such that we're not able to locate them when they are due for vaccination, of course, the number of high unimmunized will continue to pile up. And as we come to the end of the year, 2022 is just around the corner, we're still going to have a cohort of children that have not been reached at all. My also challenge is coming from the fact that these healthcare workers, we're trying to engage them by bringing them to a central location. Presently, we have identified the number of healthcare workers and LGAs to engage, and the number is so large that we actually need their attention full, such that when they go back, they will be able to implement some of the actions that we will draw from that engagement. We have also sent out templates, which we believe would aid these healthcare workers to learn how to identify their challenges themselves, because we at the national level are not the ones implementing, but the sub-national levels are the ones that we're expecting and hoping that once they implement, we're going to see the results. The number of these zero-dose children will come down drastically. The ROCA, which is the root cause analysis, is one of those templates which we have already shared last week. And we're expecting that the LGAs would turn them in this week. We'll be able to analyze these challenges so that we can put them into buckets. There are different thematic areas. It's when they come together that we'll now start to ask them what plans they have to mitigate these challenges. This week, again, we've been able to identify the logistics that are required, and some are already being put in place. The accommodation, the transportation, the feeding, because you don't want them to come and they are not concentrated. We really need their attention. Like I said, all day we're going to engage them, have a one-on-one conversation with this key healthcare workers from the different LGAs that qualify. While we pull them out is such that we will have their attention 100% if possible. We don't want them carrying out other activities while this engagement is ongoing. Lastly, I would like to say that one of the lessons we learned is that you cannot use one approach to solve the problems. We have 36 states in the country. Presently, we're looking at 145 LGAs that have been prioritized. About 80 of these LGAs were prioritized because of their low immunization coverage, which we got the data from the 2019 SMART survey. We also triangulated with the LQAS results, those that passed and failed. You can see we had to bring them out also from that bucket. We also triangulated with the outbreaks of diseases that have occurred in the past 6 months. We've been able to get those numbers and still see the same LGAs. And also the presence of the vaccine-derived polio virus, the circulating vaccine-derived polio virus type 2. We've used all of this, including the security compromised areas that we have about 60 of them, so to say, that are going through such a challenge. So all in all, we are trying our best to see that we will not use the same approach to solve all the problems. I would like to stop here. Thank you.
Thank you so much, Buma. And I see we already have two raised hands. And before then, I see the Zoom room is already full to capacity. So if you have colleagues that are saying they're having difficulties to share, to join, we may have to just share the recording with them afterwards, because we always want these hackathon sessions to be limited to a few people. And please, if your mic is unmuted, please go ahead and mute yourself unless you raise your hand and are invited to speak. So I see we already have two raised hands. So I'm going to start with the first person. That is Amel Atayi. Please go ahead and unmute yourself. And once you start by introducing yourself, tell us your city, your country, and also precise if you are an IA2030 alumni or alumnus or not. So please go ahead. Over to you, Amel.
Thank you, Charlotte, and hello, everyone. And thank you for having me here. It is always been honored for me. So my name is Amel. I'm from Sudan. I work in Pakistan for the last 6 years as PEI technical officer with WHO. And currently I left Pakistan since last 3 months. I'm working on my PhD here in Saudi Arabia. And I'm also part of IA2030 Alumni. The challenge of Buma reminds me my own challenge in 2020 when COVID-19 pandemic started in Pakistan. I was acting as a team lead for one of the province called Balochistan. So when we started, as we were not knowing, there is no specific guideline. So the government staff started working and to carry out almost all the activities, starting from the surveillance, the investigation, the screening of the cases and the treatment, which after quite very short time, within less than a week, we discovered that as partners, which is our role to contribute and help them. So we were also confused in that time. But I remember one of the best practice I considered in Pakistan, the National Emergency Operation Officer, the coordinator, has called all the partners along with government to discuss exactly what can we do to help the government staff to overcome or to control the pandemic. So after that time, the guidelines came out and we started immediately, even before the drafting the guidelines, let's deploy our own staff, because in Pakistan, the scenario is, because we are having a lot of, there is huge staff from partner side, UNICEF mainly, and WHO and other NGOs who are supporting and working in polio program. Then we agreed that let's help them in investigation, since we are we are visiting all the health facilities across the countries. Then we started doing the investigation, screening of some of the cases, doing active search. Then after that, the national team, they set up a clear guidelines. to all the partners along with government staff who are supposed to do what. So the term of reference was very clear to everyone, keeping in view that one of the good things I can call in Pakistan, we were doing Zoom meeting weekly every Wednesday, so to discuss exactly what is the situation, looking into the COVID concept, along with that, our routine immunization coverage. As also in Pakistan, we post all the SIS activities for almost 4 to 5 months. So we were doing the COVID and not forgetting that the importance of we should not miss all those children, because we will have an issue of, and already the polio virus circulation was high in that time. So I will summarize that the best thing to do in such a scenario always to call all the concerned staff together, sit down, do analysis for the issues we have, and set a clear guidelines who supposed to do what and when, with the regular meeting and discussion to evaluate the outcome. So it is over from my side, Charlotte.
Thank you so much, Amel Atayi, for sharing your experience with us. And there is a comment here from Hilary Okelo in the chat that I would love to read. It says, thanks for sharing, Buma. Human resource gap cuts across. In campaigns, we involved even student nurses as well as health workers in the private sector. It has worked well. Then in routine, we stick to government health workers. So I see there is another raised hand, Shafiq Raymond, but one thing I wanted to spell out is that for this hackathon, I'm going to be applying a country and gender rule. So the next speaker cannot be from the same country or gender as the previous one. So I'm just going to invite Shafiq Rehman. Shafiq, please go ahead and unmute yourself. Start by telling us who you are, where you're connecting from. Are you an IA2030 alumnus or not? Over to you, Shafiq.
Yeah, thank you very much. I'm Shafiq Rahman. I'm working as National Surveillance Coordinator with WHO Pakistan. And I will just like to actually enhance what already mentioned by Amal, because she was working in one of the province and being at the national level when in the experience with COVID outbreak, when COVID outbreak started, and as per Polio Oversight Board and GPI.
Okay. So
we have
Rahman, forgive me for interrupting you, but I see Amel was sharing an experience from Pakistan, and you're also from Pakistan.
I think so maybe you can have from some other place.
All right, and then we will come back to you later on. So I see Joe Andreas, I think your hand is raised. Please go ahead and unmute yourself. I see lots of people. Please, if you want to speak, go ahead and raise your hand so that we'll have some other. So Joe Andreas, please, over to you. I see your EPI Cameroon, but please start by introducing yourself.
Okay, thank you so much, Charlotte. I am Joe Andreas. I work with API Cameroon as a deputy manager, and I'm also an alumnus of the IA2030, the first cohort. So, in line with this challenge program display, in our country also with COVID, there has equally been a great impact on routine immunization. But we have held a lot onto periodic intensification of routine immunization to try to improve performance. Now, talking of the workload that has come in with vaccination against COVID-19 in the country, one of the major interventions we are carrying out at the moment is to integrate routine immunization in every intervention possible. Firstly, from the onset, it has been difficult to really integrate COVID vaccination and routine immunization for childhood vaccines. But gradually, we have started introducing it from one region to the other. At the moment, in all our 10 regions, we have not yet fully taken the approach, but already in 4 out of the 10 regions of the country, we have been able to integrate childhood vaccination and COVID vaccination in the various interventions carried out in the country. And of recent, we are trying to scale up this intervention to ensure that whenever there is childhood vaccination, the team carries along COVID vaccine. So the two go together, and in this slide, it tries to lessen the burden of the team that carry out vaccination. And we are still hopeful that this approach is going to not only reduce the workload, but also it's going to get the population to understand that these two vaccines go together, and they have different diseases that they are trying to limit. But the two vaccines are vaccines like every other vaccines that they have known. But the limitation we have in our setting at the moment is that during mass COVID vaccination, we don't do catch-up for routine API vaccination for children at the moment. The fear is that we are still aware that COVID vaccine is less accepted. But during childhood vaccination activities like the SASNIM you just talked about, and National Immunization Days and other periodic intensification of routine immunization activities, we go along with COVID vaccination. So in this slide, it's true that the COVID vaccination is rather used as an opportunity. The routine immunization is rather used as an opportunity to improve COVID vaccination and not the reverse. But again, secondarily, the goal is to help the population understand that these two groups of vaccines are all important, and one is not supposed to be used to stigmatize the other because they all have a common role to limit infectious diseases. So that is how we are trying to reduce the burden of COVID vaccination activity on the available human resource against other routine immunization. Thank you. Over to you.
Thank you very much, Jo Andreas, for sharing that with us. And our next speaker is supposed to be a woman who is not from Cameroon. So, and I saw a comment in the chat from Rebecca Gattu that said, joint planning with all stakeholders and make use of technology, Google documents that are shared among actors to allow seamless implementation of planned activities. So before we turn to the next presenter, I'd like to invite Jenny. Jenny, so far you have listened to two experiences that have been shared. What can we take away from this?
Thank you. These are really important experiences that are shared, especially with helping Buma with her challenge. I think the HRH issue is something that comes up one of the most frequently, aside from financial resources. So I think one question I wanted to ask Buma is, she mentioned that the root cause analysis template was sent out. And I'm wondering if they've received any feedback from those, because as Buma highlighted, at the national level, you have to really avoid trying to do the one size fits all, because each location has its own unique challenges. And I appreciated Buma highlighting that aspect of not one cap fits all. So trying to understand, is there feedback from the states that you can share about any of the root cause analysis templates? And then with Amel, I think that concept of coordination can't be understated, especially when there's resource challenges. And having one clear plan of action that all partners have to be on board with, and the government owning that one plan is absolutely essential. And that plan outlines who, what, where, when. It's not just a generic copy paste, but has all of the details. So thank you, Amel, for sharing that. For Jo Andreas from Cameroon, you talked about when you do the RI sessions that you carry the COVID vaccines with you. A question I had was, what is the target age group for the COVID vaccination, and how do you ensure that those coming to the RI sessions are linked in with the target age for COVID? Because you highlighted it being the childhood vaccination, which is great. I think you're following no missed opportunities approach. So just wanted to understand a bit more about how you align the age targets. I think that's it for now, but really great examples of coordination, having one plan, and no missed opportunities, using PIRI type approaches, the periodic intensification of RI, but not missing any chances to vaccinate, whether it's for the RI life course or if it's for COVID. Thank you. Back to you, Charlotte.
Thanks, Jenny. So I'll just turn to Jo Andreas maybe to answer your question.
Yes, thank you so much. For COVID vaccination at the moment in Cameroon, the target is 18 years and above. while the childhood vaccines are respecting the calendar from birth till maybe 15 months or 23 months for measles, rubella, and adolescent girl 9 years. So actually, during immunization at fixed post, what commonly happens in our setting is that the guardians, most of the time, the mothers will come along with the children. And so it's an opportunity to propose COVID vaccine to the guardians at the fixed post. But again, during routine periodic intensification of routine immunization, the team takes the vaccination service to the community. That the most common approach is a door-to-door approach that is used. So during such moments, the team will most likely meet the children and, very importantly, the guardian and other members of the household. So in the regions where this is already being used, a part of the routine vaccination, in as much as the target 18 years and above is there, COVID vaccination is proposed after sensitization, and those who are interested are vaccinated. So we are really hopeful that this approach is going to be very useful to help us improve. Thank you. Over to you, Charlotte.
Okay, thank you very much, Joe Andreas, for that. So if you're just joining us, warm welcome to you. We are sharing experiences around a challenge submitted by Buma that says health workers' attention is divided because they are engaged in ongoing mass COVID-19 vaccination, as well as many other activities at the same time, and this has an impact on routine immunization. Remember, we said the rule is you're not going to prescribe to Boma what she needs to do, but you're going to say, from your experience, this is what you have done, and these are the results that you're getting. So before I will turn to Dr. Subenu Kumare, I want to turn to Rebecca. I want to invite Rebecca, your mic is already unmuted. Please go ahead, introduce yourself, tell us who you are, where you are joining from, and if you're an IA2030 alumni or not. Over to you, Rebecca.
Thank you, Charlotte. Thank you, Rada, for giving me this opportunity. My name is Rebecca Gathu. Good morning, good afternoon, good evening, wherever you're listening from. I'm a community health nurse working with refugee and asylum seekers, urban refugees and asylum seekers at Refuge Point International. Basically, our program maybe I would say is unique because we basically focus on refugees and asylum seekers, vulnerable, who are really vulnerable to reach out to and get information. And maybe to start off sharing my experience, I'm at a IA2030 Alumni, and this gave me a platform to actually demonstrate and actually carry out, actualize my action plan that I had drafted or written during the training. Part of what I would say my strategic plan priority was commitment and demand. My key area of focus was to create public knowledge and understanding. And some of the successes that I have witnessed or is one we were able to carry out. When I say we, because I work with a team of other health officers and community health officers and community health navigators who are of refugee origin. And so far, from the time we were left to actualize our plans, we've carried out 5 virtual community health meetings on Zoom with various nationalities in attendance. So each group, each nationality had their own Zoom meeting, from the Great Lakes to other South Sudanese. And the community navigators who are refugees and asylum seekers who we work with were very instrumental in using technology to mobilize to the refugees who live within Nairobi and its environs, to actually train people to use, to get into Zoom or to be Zoom ready, and to actually participate. And we also carried out telemedical calls to refugees who called back and maybe sought to get more information about COVID-19 information. We sent out bulk SMS in English and Swahili to sensitize them on on COVID-19, but also not only on COVID-19 vaccines, but also other vaccines, especially ANC and maternal, the children vaccine, the under 5 vaccine. The other challenge, area of focus, would say, was to create acceptance and value of vaccination. One of the most important things that we noted, especially, or I noted during the virtual community health Zoom training that I had, is that religious leaders play a big role in influencing people to take up health services, and in this case, immunization services and COVID vaccines. That led to formulation of in-person community religious leaders meeting. Our community navigators, refugee community navigators, were able to map out all the refugee-led churches. And we used for every church a factor of 3 to 5 so that we could reach out to more people. And these meetings were held in sessions. And we've seen very good results. However, numbers are still challenging to obtain data so that we can say that this is our impact on the ground. And on addressing the reluctance to vaccine, I discovered that providing timely and accurate information and taking services to the people is actually will play a very big role in addressing reluctance to vaccine. Another thing that I use is especially carrying forward knowledge from on learning needs assessment from the a previous training on Teach to Reach level 1, where I constantly assess the learning needs assessment domains as we go on during the trainings, and be able to adapt and try to meet the needs, identify needs and meet them in terms of resources. Is it a knowledge gap? And this is where use of technology also comes in to address some of the knowledge gaps, and especially dispel rumors that are currently making rounds on COVID-19 and other related childhood vaccines. Use of community navigators who are refugee, using their, I would say, people's community, the community own to mobilize, translate, and provide information during, before, during, and after, so that we all constantly get feedback from the community navigators on what is happening in the community, and collaborating with MOH during in-person training, especially during the community religious leaders training. I spoke to the DPHNs of the areas that I've been able to conduct the religious leaders training, and the DPHNs have given me staff, MOH, who are actually vaccinators, and we collaboratively provide information to refugee religious leaders, and we've seen positive feedback. We've received positive feedback because some of them have, during the training, been able to register on the online platform in readiness to take up the vaccine. So some of the challenges, which I actually also would run, which are similar to bombers, are the rumors, which spread faster than accurate information. But we are using social media, the same tools, to try and provide very accurate information, but in a very timely manner and in a language that can be understood by all. Knowledge and information gap on C19 is still a challenge because there is still evolving information as new vaccines come into the market. We need to be very innovative, bring in the clinical aspect, especially what I've seen, bring in the clinical explanation in a very simplified manner.
Rebecca,
yes.
Sorry to interrupt you, but please, could you kindly round up? We're out of time.
Okay. Or what opportunities are there? Mass vaccination, especially now that we are, especially in Kenya, going into phase 3, where the government is about to roll out mass vaccination. Collaboration with MOH and other stakeholders, whether they're directly or indirectly involved in health activities, and take this platform as an opportunity for continuous learning through the community of experts that we have around. Thank you, Charlotte.
Thank you very much, Rebecca. We really want to hear other experiences from other participants. But as you can see, the 30 minutes that we programmed for this session are long gone, but there are still so many comments in the chat. There are interactions that are ongoing in the chat, and still a raised hand. So I would like us to, if you are okay for us to continue with this interesting session and to get more experiences, looking at another challenge that is similar to the challenge of Buma. Can you type more in the chat? More in the chat, like as I have just done. So please just go ahead and type more in the chat if you want us to continue to look at a second challenge. That is okay. So thank you very much for that response. So our second challenge, although the challenge owner is not with us in the room, and I'm sure when I'll turn towards Jenny and the others that are with us here in the room, they'll comment on your experience, Rebecca. Thank you for sharing that, as well as the experience of the challenge, the experiences that we shared based on this challenge from Boniface Makelemo, that is from Tanzania. He's working at the subnational level, and his challenge was working to improve routine immunization coverage by tracking and vaccinating defaulters, while most of the resources, that is financial, human, and time, are prioritized to working on COVID-19 emergency activities. So COVID-19 emergency activities that involves response activities as well as a vaccine rollout. So it makes it difficult for him to be able to implement his planned activities, because priority now is on COVID-19 vaccine response. And he said that the strategy he's been trying to do is advocacy to keep personnel who work on the priority activities, as well as to work on priority activities as well as on routine immunization. And he says that he's considering reducing the scope of the project he wanted to implement due to limited resources, and also changing his project area. So he may find himself, instead of doing what he intended to do large scale, do it at a lower scale because of this challenge. So after seeing this challenge from Boniface Makelemo, even though he is not here, he may join us at any time, and or he may view the recording of the session to see what you have shared as far as this challenge is concerned. So I'm going to turn towards Dr. Subendu Kumar Ray. His hand was raised for quite a while to be the first to share his experience. And unfortunately, it's as if he's no longer in the room with us. Meanwhile, I'd like to invite you to please raise your hand, looking at this challenge that is faced by Boniface Makelemo in terms of resources, that is improving routine immunization within the context of COVID-19, where most resources, that is human resources, financial resources, and time, are mostly turned towards COVID-19, the response to the COVID-19 pandemic and vaccine rollout. So what have you been doing in your context to balance this? I see Dr. Suresh Kumar Dalpada says need to strike a balance between demand and supply. So I see Olawale Oladimeji, your hand is raised, so please go ahead, and you're already unmuted, so please start by introducing yourself.
All right, thank you, Charlotte. My name is Olawale Oladimeji. Speaking from Nigeria. I actually worked with WHO in South Africa on COVID response last year and up to this year before I came back. So last year, I'll just talk about our experience, and probably it can provide some insight for Boniface. So last year, we supported COVID response basically. So it was more about the response, isolation, and contact tracing. So, but with this year, with the onset of the vaccination, so the pillars initially were more of the response and the vaccination. But along the line, from WHO's perspective, we discovered that essential health services were, the indicators were declining. So we had to focus on three pillars, which is what we also engaged the Department of Health in South Africa on, which they also brought in and the country worked on. Three pillars: one, the COVID response; two, the vaccination; and the third one is essential health service. That is where the issues of vaccination, maternal health, child health, and other things also come in place. So we, along with the DOH staff, Department of Health staff, able to integrate these together so that each of the pillars don't work in isolation, since the resources were limited, both financial and human resources. So as much as possible, we will go on community engagements for COVID-19 vaccination. We also try and also engage community members on other routine immunization and also other things about HIV, TB, because there are a lot of dropouts and dropout rates because of the emphasis of COVID-19 response last year. So we have to integrate these three pillars together. So I think working with this perspective will also help reduce the challenge, because the amount of funding, resources are limited, both financial and human resources, and also time. And so by the time everything was prioritized for COVID response, it affected other essential health services. So what was done in South Africa was that we were able to integrate the three pillars together: the response, the vaccinations, and also other essential health services, including childhood immunizations, maternal health, child health, and other things. So I think with this experience, this would also help if it can integrate its projects along the line with COVID-19 response and other things. Over. Thank you.
Thank you very much, Olawale, for sharing that interesting experience. And please go ahead and raise your hand if you want to help Boniface to overcome this challenge. And I see there's a comment in the chat from Matthias Besong. Okay, it was still concerning Buma's challenge, but since it's along the same line, I can still go ahead and read it, and then I'll turn towards Jenny to hear what her thoughts are. And do not hesitate to raise your hand if you want to share your experience, an experience that can help, because we know on a day-to-day basis, wherever you are, you're making a lot of efforts to ensure continuity of routine immunization services in spite of the COVID-19 vaccination and response. So Matthias says, another issue I've noticed that is making Otobo's challenge even bigger is the way the Ministry of Health is structured at the district level. The health department at this level run almost independently of district government. I have seen local governments say they can't help support health workers at this level because they don't work for local government area, that's the district. There should be a conscious effort at the national level to get buy-in on the state, okay, and especially local government authorities on vaccination programs. So Matthias, we really like to hear you share your own experience. What have you done? What are you doing within your own context? So I'm going to turn towards Jenny. You have seen first and foremost Boniface's challenge, and also listened earlier on to Rebecca, and now to Olawale. What is your take here?
Thanks, Charlotte. Yeah, I think that, the way that Rebecca highlighted use of technology, especially with bulk SMS, is really great. And I think for places that have the financial support to integrate technology, that can really help to address mass issues. So I think that's a great example. But especially when Rebecca mentioned issues with urban refugees, they're finding ways to reach urban refugees using community navigators. You're not on that important cadre that refugees and asylum seekers in urban or even remote rural are addressed. So thank you, Rebecca, for raising that issue. And for Boniface, the experience from South Africa, I think, is really, really valid, and trying to bring in the, integrate the pillars. I think that places that have had more experience with COVID, this is a good platform for peers to share with each other. But I'd like to also hear a bit more from Buma. In the text, she said they got feedback from the root cause analysis template that one of the challenges with HRH and doing more integration is that when health workers retire, they may not be replaced in the same locations where they retire. And so to me, that's an issue that both Buma and perhaps some of the issues that Boniface is facing relate to. So I don't know if there's anyone that has experience with some of those HRH issues, or if Buma has any comment about what do you do when health workers retire? What can you do in those specific locations? Because if a root issue is HRH, how are we going to go about addressing some of those things in the precise locations where there are shortages? Because sometimes urban cities, more urban areas have maybe an overabundance of health workers, and many health workers may not want to be placed in more of the rural remote locations. Back to you, Charlotte.
Thank you so much, Jenny. So I saw Matiranki, your mic was unmuted. I don't know if you have an experience to share around this particular challenge, especially taking into consideration all that which Jenny has shared. So Matiranki, I'm asking you to unmute yourself. Matiranki? Okay, maybe you unmuted yourself accidentally. So Buma, I don't know if Buma, you want to come in here? If not, there are some comments in the chat there's a very long comment from Joyce Murithi. So Joyce, I don't know if you're able to unmute. If you're able to unmute, can you just go ahead and share your thoughts with us? Joyce Murithi. Hello, Joyce. Okay, maybe Joyce is not able to unmute, but she was saying, thank you, Rebecca. That was very informative presentation. I'm working in Kajiado, that's also in Kenya, and I've realized that one-on-one engagement with religious leaders is worthwhile investment, because once they understand about the benefit of vaccines and need to vaccinate, they immediately take upon themselves to encourage their congregants to take COVID-19 with confidence and no fear. In my case, the biggest challenge is that I am not on the ground, and secondly, that we do not have resources and tools. Okay, so the other thing is that the partners whom we have identified and who have agreed to work with me have not come together so that we plan on who will be doing what and how. So, okay, I see Joyce, she said she had to leave early, so she may not be able to intervene. And there is also a comment in the chat from Mita Vashi, advocacy at the highest level on vaccine preventable disease threat. So I see many people are sharing their experience in the chat, probably because you're having connectivity issues. It's a lot more easier. And it's no problem for me to read those comments. So you say advocacy at the highest level on VPD stress. Okay, I see Mita, your mic is unmuted, so please go ahead.
Yeah. Am I audible?
Yes, you are audible. So please start by introducing yourself.
Yeah. One important is advocacy at the highest level on VPD threat. We need to clearly communicate about the vaccine preventable disease threat.
Please, excuse me, Mita, can you start by introducing yourself, telling us who you are, where you're connected from?
Yeah. I'm Dr. Mita Vashi. I'm a surveillance officer with WHO working in Mumbai in India. And my job is basically to give technical support to government on RI strengthening, VPD surveillance, and even COVID vaccination technical support. That is what we do. And here also, like during the COVID time, health staff was busy managing COVID vaccination now, and strengthening RI. RI was, initial days of COVID, RI was really poor. So there are 2-3 things which were done here by the local municipal body. One was hiring contractual manpower so that the routine immunization staff, the helper staff, is free for contact tracing of COVID as well as for routine preventive activities like RI conduction of RI camps and all. Second thing is we need to communicate VPD threat at the highest authority very clearly, that if RI is not improved, then there is a threat of vaccine preventable disease, and RI should be taken as priority. That needs to be communicated with the help of data by strengthening probably VPD surveillance. So these are some of the thoughts that I wanted to share.
Okay, thank you very much, Mita Vashi, for sharing these thoughts. And we have just about 10 minutes. There was a comment here from Hilary Okelo that I find very interesting for Boniface. He says, thanks, Boni, for sharing. Getting separate funding may be difficult, but try to integrate your plan into routine immunization plan. It has worked out for me very well. The best thing is that you have the knowledge and skills. Use the system in place to implement your action plan. Thank you very much, Hilary, for that comment. And I see Buma responding to Jenny as well in the chat, and Amel that's talking about retired health workers. The district team should have a reserve pool of some workers to replace retirees. In case of hard to reach areas, always involve the local community to find out workers to be trained to carry on with the activity. So thank you all very much for these challenges. Before I turn to Jenny for maybe closing remarks and what the challenge owners really need to take away from the discussions today. So I can't just turn my back on a raised hand. So I'm going to invite Amsalu Sequeira. Amsalu, please go ahead. You have 2 minutes, unmute yourself and share your experience with us. But please do start by introducing yourself.
Thanks so much, Charlotte, for bringing this agenda into the discussion. My name is Amsalu Sequeira. I am working in Ethiopia, UNICEF country office as immunization specialist. So I just wanted to thank you for choosing this topic as resource and attentions are diverted to COVID-19 vaccine, leaving the child immunization particularly. So what we are doing here is, I mean, most of the immunization services provided at primary healthcare unit level, at health center and health post level. So what we focused is to strengthen the primary health care units to identify their catchment areas, to sort out those underserved villages in each community, particularly to identify the 0 dose, and to discuss with the community volunteers on the importance of immunization, because the child immunization has been there for the last 3 to 4 decades, and then they understand the benefit of child immunization. So we are communicating the community volunteers and influentials, particularly the opinion leaders, to convince the caregivers to bring their children to immunization service as they have been known. With regard to integration with COVID, I mean, there are a lot of hesitancies in the acceptance of COVID vaccination, and the target is also different. The routine immunization is for children, and the COVID is for adults aged to be, I mean, above 18 years. So what we are trying to convince is to increase the uptake of COVID vaccination by giving an example of the routine immunization. So that is what we are doing, but still the COVID uptake is challenging, and it has definitely impacted the routine immunization. And this is good to continue this such type of discussion, I think, and share experience. Thank you. Over to you. Sorry for taking some time. Thank you, Charlotte.
Thank you. Thank you so much, Amsalu Sequeira. It was great to listen to you. And I see there are many more comments that are coming in the chat. Unfortunately, I would love to read all of them, but we may not have time. But I'm just inviting you to look at the chat, look at the comments that are being shared. What can you pick out of those experiences? So before we move forward to look at some key next steps, I'd like to turn towards Folake, who has been listening. Like she said, she came to listen to you, who has been listening to you attentively from the start of this session. Folake, what are you taking away from these discussions this evening? And please unmute.
Charlotte, would you like to repeat that? Sorry, I had to attend to something quickly.
Okay, so I was just saying, after listening to the discussions and the experiences that are being shared, what are you taking away from this discussion?
First of all, let me thank you all. This has been so fantastic, just learning and listening from your experiences. Diverse experiences at both national, subnational, right at the front line. The working group is focused on immunization programs for primary health care and universal health coverage. And one of the main things that we've tried to elevate attention and focus has been on safeguarding and strengthening routine immunization during COVID-19 vaccines rollout. And the conversation and dialogue today was just really great, starting with issues around adequate health workers to be able to continue this work. Also, even looking at the issue of surveillance and using it as a powerful tool to engage with the different leaders, draw attention. There were things that I heard around how do you also, I think this was the experience from Cameroon, where they're able to deliver routine immunization vaccines at the same time of offering COVID, sensitizing and offering COVID-19 vaccine. I found it very interesting that especially in places where there's high hesitancy towards COVID-19 vaccine, I found it very interesting that it was actually the routine immunization that was bringing some level of confidence to the community on COVID-19 vaccines. I found that extremely very interesting as well. And I would say maybe just one more point that I would like to highlight, and that is it's really ensuring that the risk of not vaccinating children and putting in tailored strategies for catching them up. I heard that very clearly. It's not going to be a one size fits all. It's going to need to be adapted to particular context and setting using different approaches, but also ensuring that the risk of not paying sufficient attention to catching up those missed vaccinations, but also continuing to maintain and strengthen the immunization uptake will lead us into greater disease outbreaks and take us even farther back than what the disruptions from COVID has done. So this is certainly an area that we need to pay particular attention. And really hearing from all of you today on behalf of the working group on strategic priority area 1, which is immunization programs for primary healthcare and universal health coverage. Really want to thank you because you've given us a lot to think about that will inform the different guidance and policies and tools that we would like to support with. So again, really just huge thank you for sharing and inviting us to share this time with you as well. Thank you so much.
Thank you very much, Folake, and I'm sure this is not the last time we'll be seeing you. So I want to invite everyone here, if you have not yet done so, get your ticket for Teach to Reach Connect 4. So I've turned towards Reda. Reda, what should participants expect from this new edition of Teach to Reach Connect that will hold on Friday, the 10th of December, 2021? Over to you, Reda.
Thanks, Charlotte. So first of all, many people referred to the fact that they are alumna or alumnus of the IA2030 course that we have. The second cohort just finished for the English. This is a course we do with WHO. So there's a lot of people who have spent time, studied Immunization Agenda 2030. We want to build on that. And in the last few weeks, we've been discussing with the working group, the IA2030 working group on strategic priority 1 on universal health coverage in primary healthcare, as you all know, how we could recognize and listen and learn from your experience and you connecting the dots between the global strategy and the work that you are doing every day and looking ahead, not just to tomorrow or next week or next month, but looking forward to how to make progress during the coming decade. So we've decided to place the entire Teach to Reach event under the banner of Strategic Priority 1 for the 10th of December. And as you know, it's a quarterly event. So we may choose different strategic priorities for the March, June, and September events next year. But for the 10th of December, two things are going to happen. One is we're very pleased that the Working Group 1 will be organizing will be inviting you to the IA2030 consultation on safeguarding and strengthening essential immunization and primary healthcare during COVID-19 vaccine rollout. So this session will be co-chaired by Folake, who is here with us tonight, and Polen Fodraman, a scholar alumnus based in Ivory Coast. And the point will be to identify opportunities to not only safeguard, but also strengthen immunization and PHC, as Folake said, because we simply cannot put this off. And so all three of the networking sessions, parallel to this consultation, will be also focused on different key areas of focus of Strategic Priority 1. And we hope through this that you can do the same kind of networking on the 10th of December, as you know, as many of you know, is one-to-one meetings. So rather than being in a big group where only a few people can speak, you can really have those one-to-one meetings and discuss and share your experience and compare notes between maybe somebody from your country, it may be somebody from halfway across the world. We found that to be incredibly productive and interesting for all involved. And we're very pleased that there are now members of the global community from the Working Group for Immunization Agenda 2030, who will be actively joining us, participating, listening, and contributing to the work that you are doing every day. So that's the next rendezvous for everyone committed to Immunization Agenda 2030 and achieving its goals. Thank you, Charlotte.
Thank you very much, Reda. And if you have not yet registered for this event, please, the link is in the chat. Go ahead and do so as soon as possible. All right, so that said, one other thing you need to do before Friday this week is to ensure that you have submitted your individual acceleration report. So please check your mails, you get the individualized link and go ahead and submit your individual acceleration report. Remember, it is a certification requirement. And if you have not yet submitted your challenge, we still have one session that is next week at the same time. Jenny and I will still be here for another session. So please go ahead and submit your challenge. So I'm going to turn towards Jenny for the closing remarks and the key takeaways from today's hackathon. Over to you, Jenny. And thank you so much for being here, all of you.
Thanks, Charlotte, and thanks, Folake. It's good to hear a familiar voice, and great to hear your summary of some of the key takeaways. As I read through the comment box, there were so many tips and tactics from many, many different participants. And I think part of this peer exchange is pulling from those specific things that people say and following up with those individuals to say, you know, I have a similar thing, you were able to solve it in one way or another. Can you give me more advice? So this session isn't just a one-off. It's for you to connect to people who have made comments either orally or in the chat box of things that they've done. For example, Bala, you talked about visual cues that you're using for tracking missed vaccination. Many others talked about, you know, what you do to make sure that there's gaps are filled when a health worker retires. There was examples about missed opportunities in vaccination. When you have an RI session, I love the idea, especially that Njo Andreas shared, of making sure that you're building on, you have a different target group, but the mothers, the caretakers, the guardians who are bringing their children are people that you can target. There was lots of examples about technology use cases, bulk messages. So this isn't just a one-off thing. Please contact other peers who've suggested ideas or have experience in particular areas that you have challenges. I know we're over time. This has been very helpful. A lot of great crowdsourcing, and this is the collective thing that we can do to help solve particular specific challenges. Thank you, everyone. We're looking forward to next week. And on Monday next week, we'll be talking about successes, and on Tuesday, the last session on challenges. So thanks again, and looking forward to next week and what you're doing in between now and next week. All right, that's goodbye from me.
Thanks so much, Jenny. I'm going to allow ask everyone to unmute. So please go ahead and unmute yourself. You can just say your byes, your good nights, your good days.
Bye, good night, bye.
Good night.
Good night, everybody.
Bye. God bless you all.
Go ahead and do so.
God bless you.
Good night.
Thank you.
Bye.
Bye.